Professor Alan Marmorstein from Mayo Clinic. Welcome, Professor.
Thank you.
First of all, tell us a little bit about the scope and scale of your work at the Mayo.
Okay. So the primary interest that I've had now for some 2 decades is best vitelliform macular dystrophy and other inherited maculopathies, and then to a lesser degree age-related macular degeneration. We've been working to understand the mechanisms that underlie Best disease, and more importantly, I think, to try and find therapies that could be used across the board to treat Best disease and other inherited maculopathies, and again, of course, AMD if it's applicable.
So what is your core approach to this problem?
Well, that's changed through the years. It's changed partly due to the technologies that are available, and it's also changed due to what we found, obviously, in the data set. So initially we were working with animal models, and the animal models led us to certain directions, but we realized we needed to expand more into models that were representative of humans. Mm-hmm. And so today we're using induced pluripotent stem cell derived cells. So these are basically disease in a dish models where we take fibroblasts from patients who have given us a small piece of their skin. We reprogram them into stem cells that are capable of becoming basically any cell in your body. And we make them into RPE cells. And the RPE is the cell that, at least in the diseases that I have my greatest interest in, is the one that's affected. It's also very important for another reason, and that is your photoreceptors can't live without them. So if we have RPE cells that we make from individual patients, and some have disease and some don't, then we can compare what the differences are and try maybe to find either small molecules or other approaches, some cell-based maybe, to bring back what they should be doing, like we have in the control population, if you will.
So once you generate these iPS cells, what types of research are you conducting?
Well, much of it is physiological. For Best disease, the protein that is not functioning correctly, and I have to say it's not functioning correctly because it's not functioning, but it doesn't function the way it's supposed to. And the problem is we don't really know how it's supposed to. So we're evaluating 2 things. One is, how does having the dysfunctional protein, if you will, result in changes to what the RPE normally do? And then how can we get the RPE to get back to the state that they should be in? So these are assays of things like ion channel currents. A very important property of retinal pigment epithelia is that they eat, if you will, the outer segments that are shed by the photoreceptors. And to some people this makes no sense, but what you have to think of as a photoreceptor is a long, it's kind of like this cup that's in my hand here, and this cup has these little striations. And each day, the photoreceptor is making more of them. And as they extend further, the ones at the very tip drop off. And the RPE eat those so that they don't build up in the space in between the retina and the RPE. In fact, if they do, you have a disease that it's a form of retinitis pigmentosa, and that's not a good thing either. It looks to us as if in Best disease there are some impairments in that process, that the RPE can't clear those outer segments the same way that they can in people who don't have Best disease. I'm not 100% sure of that, but that's what we see in the animal models, and that's what we're seeing now in our iPS RPE cultures. So the question is, how can we find a way to restore that function so that in the patients everything is the same as it is in everybody else?
So what approaches are you using to solve the problem?
Well, there's a couple of them. We are doing some drug screens, so small molecules and plates with our patient cells versus non-patient cells to see if we can bring those functions back in line with what they should be. And the other is cell therapy. So we're very interested in being able to take a patient's cells, fix those cells, so get rid of the mutation, and then turn them into RPE and put them back in their eye. Now, why do we have to fix them? The reason is that Best disease, at least, and it's the other inherited maculopathies, are diseases that are caused by mutations in specific genes. And if we take your cells and we put them back in your eye without fixing the gene, you're still getting the cell with the bad gene. So we're applying new technologies in the field of gene editing to the, well, actually I shouldn't say new. We're actually using older technologies for that, but not the CRISPR-Cas9, for instance, that is very common today, but an older technology called TALENs. And this is hopefully going to repair or replace that gene so that it's no longer the bad form, leaving the wild type, the normal form behind, and let us then put those cells back in a patient's eye and have them functioning as they should.
How far is that from the clinic?
Well, to a degree, it's already there. There are phase 1 trials going on using iPS-RPE in Japan. There are 2 people today that have received that in Japan. We had a great report in the New England Journal of Medicine not long ago about the first one. It's 1 person. For this case, it was found to be safe and potentially effective, and this was a patient with AMD. Now, before everybody starts running to Japan to get the iPS-CRPE transplants, we have a lot more work to do. But there are a couple going on there, and there are also some patients in the world now who have received ES-derived RPE cell transplants. That's happening in the US and it's happening in the UK. But these are all phase 1 trials, so this is safety testing basically. And safety testing is critically important because it tells us it's safe. Once we get past the safety testing, then the next stage, of course, is going to be to look to see if doing this is helpful. And then if it looks like it's helpful, then we test on an even broader level, and that's what the phase 3 testing is. Can we take what good effects we've seen in a smaller group and then take that to a larger group? And that's when it really is the thing that everybody should consider going in. Today we're at a very early stage. Very few people in the world have received these transplants. There's a lot of promise. I think we've got, I want to say 3 to 5 years because we all want to say 3 to 5 years, but realistically it's probably a decade until it's a common practice at least. And then to tack on the gene editing end of things to fix the gene and do the transplants is solidly that 10-year period.
Are there specific areas that you see as being on the leading edge? Which types of patients are going to be most amenable to the therapeutic approaches that we're talking about?
Well, that's a difficult thing to answer. I think it depends on the way that things go. I'm putting my eggs in the basket of cell-based therapy. There are others who are looking at gene therapy, for example. Gene therapy is a little bit more mature, maybe. We have products that are approved, at least for use in Europe, for gene therapy, not in the eye, mind you, but in other diseases. There are issues there with reimbursement from insurance companies and so on that yet need to be worked out. Spark Therapeutics, as I understand it, is going for FDA approval of their gene therapy for Leber's congenital amaurosis due to RPE65 mutations, and that hopefully will become approved. And again, they're going to have to work that out, but that's a very small population of patients. Right. For Best disease, there are people looking at gene therapy right now, certainly for the recessive version, autosomal recessive bestrophinopathy. We're a little ways from getting that FDA approval, I think, there. But we don't know yet whether it's effective. Is gene therapy effective for ARB? Is cell therapy what you need for ARB? Is gene therapy going to be effective for Best disease? Is a cell-based replacement type therapy like I'm interested in? We're just not there yet. And so to say this population or that population would be, beyond speculative. But what I will say is that the patient who comes in and has that documentation, who's had the genetic testing, who's had thorough characterization of the progression and time course of their disease, is the patient that we would be looking for if we're testing something in early trials.
So as you see it, you're developing an ecosystem that will support both gene therapy and a stem cell-based approach, either alone or in combination with each other.
On the broader scale of retinal degeneration and macular degeneration, yes. I think it's going to be a combination of both. Certainly in inherited diseases where the gene is missing, gene replacement therapy is gene therapy. And we're at the point again where, at least in other countries, there are approved therapies. There probably will be very soon in the US. And I think, it's been a slow process. And as more therapies get approved and as the billing issues with insurance and so on get worked out, I think you're going to see an exponential increase in gene therapies that become available. And then maybe they will go beyond gene replacement therapy. Maybe we'll be able to do gene knockdown therapies. There are certainly people who are working on that for dominant diseases like Best disease. And then the cell therapies are coming along, and I think actually we've got a bit of a head of steam that's beyond where maybe gene therapy is today as well. You know, the FDA looks at autologous tissues differently than it does things like viral vectors. One of the reasons that some of these stem cell clinics that are not doing very good work can do this is because they're using your cells. If they go in and they extract cells from a fat biopsy that they take from you as they're doing the procedure, because it's your cell and because they haven't actually altered it in any way, they're not regulated by the FDA the same way that we are if we're going to do something like reprogram your skin cells to make stem cells and then turn those into yet another cell type. That's something the FDA regulates very highly. Now, having said that, the FDA is also looking into what changes they need to make to regulate.
You know, the last question really is, you know, how you, if a patient is in a situation, many retinal specialists have different thresholds for testing. And some patients feel uncomfortable going and researching the internet, and they're going to ask the doctor for certain tests. If a patient feels that they're not getting the full repertoire, who do they go to at the Mayo Clinic?
Okay, I get to give a plug for the Mayo Clinic. We have an appointment hotline,
Right.
and you can find it at the Mayo Clinic. It's www.mayo.com. Just search at that website for ophthalmology, or call our general appointment hotline and set up an ophthalmology appointment, and we're happy to see you. What I would say is, if you're not getting what you want, go to somewhere else, be it the Mayo Clinic or someone else. You're in the driver's seat as the patient. They're your eyes. They're not the doctor's.
Professor, thank you so much for this most insightful and enriching interview. Thank you again, and we look forward to watching and learning as your research unfolds.
Thank you. Very welcome.